the mucous membranes. Older infants and children can use a nasal cannula, consisting of a length of tubing with two prongs that fit into the nostrils to allow oxygen delivery. The cannula can deliver concentrations up to about 50%. A mask, often used with adults, is really not well tolerated by infants and small children. Older infants or young children may be placed in an oxygen tent or a mist tent. A major problem with the tent is difficulty in controlling and maintaining a consistent concentration of oxygen within the tent's environment. More critically ill infants and children may require mechanical ventilation as well as supplemental oxygen. There's continuous positive airway pressure, or CPAP, delivered primarily with nasal prongs, but also via tracheostomy tube, endotracheal tube, or face mask. CPAP applies a constant low pressure to keep the alveoli from collapsing on expiration. Mechanical ventilation can also be delivered via ET tube or tracheostomy, high-frequency oscillatory ventilation or jet ventilator, and extracorporeal membrane oxygenation. What about complications? It is important to remember that oxygen, while essential for life, is a potentially toxic substance when administered improperly. The tissues most vulnerable to the toxic effects of oxygen are the retinas of premature infants and the lung tissue of people of all ages. Complications related to oxygen therapy include retinopathy of prematurity, resulting in retinal detachment, necrosis of the nares and nasal septum associated with use of nasal prongs, microbial growth or infection primarily related to humidifying equipment, bronchopulmonary dysplasia, destruction of lung tissue, and oxygen-induced carbon dioxide narcosis related to long-term pulmonary disease and oxygen therapy. Signs that indicate oxygen toxicity include a dry and non-productive cough, substernal chest pain, stuffy nose, sore throat, nausea, and vomiting, fatigue, and hypoventilation. What diagnostic tests are related to oxygen therapy? Pulse oximetry, arterial blood gases, exhaled CO2, and chest x-rays. That brings us to the nursing care. You'll approach oxygen therapy with the same care you'd use in giving medications, following the same principles, such as the 6 rights. Even though respiratory therapists usually have a primary role in setting up and maintaining oxygen equipment and delivery, you must be familiar with and able to use and troubleshoot the equipment as well. When administering oxygen, you'd assess the child's need for supplemental oxygen and monitor oxygen saturation levels on an ongoing basis. To do this, you'll use pulse oximetry, a non-invasive way of measuring the oxygen saturation level in the child's blood. Arterial blood gases provide more detailed information related to respiratory status. Carbon dioxide levels and pH are measured in addition to oxygen and other products of metabolism. And be sure to assess respiratory status, work of breathing, breath sounds, color, and level of consciousness. In collaboration with the respiratory therapist and the physician, you'll identify and maintain the appropriate delivery system and related equipment. That means flushing the tent or incubator hood with oxygen. Secure the nasal cannula in place, especially for more active children. Plan care to limit opening the incubator or tent, and be sure the tent is tucked in securely. And ensure proper ventilation within the system to prevent the buildup of CO2. For children who will be sent home on oxygen therapy, you'll teach the family about care and use of all the equipment and about safety issues such as avoiding any open flames and cigarettes and having electrical appliances checked for safety.
Let's begin our review of pediatric cardiovascular disorders with congenital heart defects. They are among the most common of all birth defects and are the leading cause of birth defect-related deaths. Some congenital heart problems are so minor that the infant remains apparently healthy for many years after birth, while others are so severe that they are immediately life-threatening. Heart defects develop in the early weeks of pregnancy when the heart is forming, and can affect any of the different parts or functions of the heart. Some babies and children with heart defects are essentially asymptomatic, and a heart problem is only suspected when a healthcare provider hears a murmur. Of course, children with normal hearts can have innocent or functional murmurs, so diagnostic tests might be done to rule out a pathological cause. Congenital heart defects can prevent the proper flow of blood to the lungs or other parts of the body. This leads to congestive heart failure with hypoxia, tachycardia, and dyspnea, especially during exercise or stressful activities, such as in infants, the work of feeding, which could result in inadequate weight gain. Edema of the legs or abdomen or around the eyes is another sign. Some heart defects cause cyanosis, usually appearing soon after birth, during infancy, or even later in childhood. Children who have cyanosis may tire easily, exhibiting symptoms such as shortness of breath and fainting, made worse with exertion. Some children assume a squatting position frequently in an effort to make it easier to breathe and to decrease venous blood return, which in turn decreases the heart's workload. Intolerance of a supine position is fairly common in infants with heart defects because of the congestion and hypoxia that result. In most cases, the reason a baby's heart develops abnormally is unknown. Both genetic and environmental factors play a role. Women who are poorly nourished and older mothers are at risk. Women who contract rubella during the first 3 months of pregnancy have a high risk of having a baby with a congenital heart defect. Other viral infections, such as Coxsackie virus, can also contribute. Certain medications are also known to increase the risk, including the acne medication isotretinoin, trade name Accutane, lithium, and anti-seizure medications. Alcohol abuse during pregnancy also increases the risk of heart defects, so babies with fetal alcohol syndrome often have them. Cocaine use during pregnancy also increases the risk. Chronic illnesses such as maternal diabetes represent an increased risk for congenital heart defects, although the risk can be reduced if blood glucose is tightly controlled before and during pregnancy. Women who have PKU are also at high risk of having a baby with a heart defect, unless they follow the recommended diet beginning before pregnancy. These malformations are more likely to occur in siblings or children of people who have heart defects than in unaffected families, strongly suggesting a mutagenic connection. Heart defects also appear as a component of a wider pattern of birth defects. For example, more than 1/3 of children with Down syndrome have heart defects. Your role is to identify children with signs and symptoms of congenital heart disease and make referrals for immediate medical evaluation. You'll also provide supportive care and education for the family about caring for the child at home. Signs and symptoms of congenital heart disease are failure to thrive, poor weight gain, cyanosis, pallor, decreased peripheral perfusion, distended pulsating neck veins, active precordium, irregular heart rate, murmurs, clubbed fingers, crackles, fatigue with feeding or activity, choking, stridor, increased work of breathing, and diaphoresis. Let's look at some congenital heart problems that cause increased pulmonary blood flow. First, patent ductus arteriosus, or PDA. In utero, much of the fetal blood flows through the ductus arteriosus from the pulmonary artery to the aorta, bypassing the lungs because the lungs are not yet in use. The ductus arteriosus should close soon after birth, establishing normal blood flow. With a PDA, patent ductus arteriosus, the ductus arteriosus fails to close at birth or reopens due to hypoxia. Blood continues to flow from the higher pressure of the aorta into the pulmonary artery, with oxygenated blood recycled back to the lungs. There is an overload of pulmonary circulation and an increased workload for the heart. Signs and symptoms are dyspnea, bounding pulses with a hyperdynamic precordium,